HIV. And provision of your ARTs and clinical management of these pregnant women or breastfeeding women living with HIV and their exposed infants. Okay. Now, this has been shown already to us, the study by Dr. Edsel Sandanya, that shows us that even after just 1 year of ARV treatment, our patients are developing resistance to your primary drugs for your HIV. Particularly, look at your nevirapine and efavirenz, which has about 8.5% of the resistance, overall resistance. This is our first line prophylaxis, okay, for our infants. And thus, in our AO, these are the list of drugs, AR drugs, that are locally available. Okay. So the problem here is we don't have enough second-line drugs to use even for treatment and also for prophylaxis. So in the AO, but this is not in the AO on the PMTCT. This is in the AO on the treatment. Kaya hindi ko sinabi. So this is our now our recommendation for infant prophylaxis for different clinical scenarios. The first two here, the first two columns are actually for low-risk infants, meaning the mothers have been on ARTs, okay, at least for more than 4 weeks, either breastfeeding or on replacement feeding. Then we can start nevirapine as our one drug as our prophylaxis, and the duration may be about from 6 weeks and can be longer if the mother is breastfeeding up to 12 weeks. Now, for the last two columns here are for the high-risk infants, meaning these infants are defined as those born to women with established HIV infection have received less than 4 weeks of ART at that time of delivery. So it's really very important for us to determine the duration of ART that was given when the mother has started the ART treatment, because we now give different prophylaxis for the infant. Okay? Those born to women established to have HIV with viral load of more than 1,000 copies per ml. In the data earlier showed to us, the PGH data, ano yung nakita nyo kanina? Diba, there are 5 women, actually who have more than 1,000 copies. So that means nasa high risk siya. But more importantly, majority or 65 of these women doesn't have any viral load done during delivery. So anong sasagot namin dun anong sasagot namin sa prophylaxis? Okay? So will depend on the other factors. Okay? So again, the third kind would be women with incident HIV infection during pregnancy or breastfeeding. That meaning she just knew about the positivity of the test even during breastfeeding, or identified during the postpartum period or without a negative HIV test prenatally. So, for these high-risk infants, we are now giving them the treatment, meaning we are giving them 3 drugs already, okay, at birth. And this treatment, treatment is equal to prophylaxis. Okay. So, What are the recommended drugs that we use now? This is actually from WHO also, but we just adapted this, no, in the AO for the infant prophylaxis. Um, we are giving three drugs, and in the case that the infant becomes positive, then we just continue it. Okay? What are the considerations for the recommendations of the prophylaxis? No? Number one is the limited availability of drugs in appropriate formulations. Not all of these drugs are in suspension form. So, for example, we had a problem with abacavir, yung ABC. The abacavir is available only as a pellet. No? So, what do we do with that? In a newborn, di ba? So we have to do the paper tabs because it would depend on the weight of the infant. Okay, so we do paper tabs and then we give it every day, for so imagine the agony of the baby and the caregiver also. Okay. Next would be the long-term toxicities of these drugs because they are being given at least for 6 weeks. Okay, we have several. Once they develop the difficulty with adherence to the drug. Remember, these are infants, newborn. They spit every now and then. So can we be assured that the drug has been taken? Next is the possibility of pre-existing viral resistance due to the ARV drugs given to the mother. So we don't know. So we don't know if these drugs will work for the infant because the mother already developed resistance to that certain drug. Okay? So just some notes, diagnosing HIV in infants exposed to HIV, we have to use because we all know that maternal antibodies would cross the placenta. No? And so antibody testing is not recommended prior to 18 months of age. Okay, the serological test is the antibody testing. So we don't recommend to use that test for infants. So what we do is the virological test, which is your HIV DNA or RNA PCR. That would cost about 4,000 pesos. Okay, so but it's covered by the DOH now because we have this AO. And but we have to repeat the test if the baby is being breastfed. Okay, so once the breastfeeding is discontinued, we do repeat the test 3 months after discontinuation of breastfeeding. Some WHO updates. Okay, the even in the virological test being used to diagnose the HIV among infants and children younger than 18, and then ART or the ARTs drugs should be started without delay. No? So once you have a positive test, one positive test, we start with the treatment. Okay? Or continue depending if the patient has been on prophylaxis with 3 drugs. So we continue it until we do the second test. When the second specimen is collected to confirm the initial positive virological test. Next, confirming all these tests would decrease the false positivity also in the initial test. But the WHO is now recommending the use of your nucleic acid-based assay. This is a 4th generation. As of now, we are just using the 3rd generation Western blot test. Okay, so I hope we can actually adopt this one. Next, the update on postnatal transmission, which is through breastfeeding. So the dynamics has now been shifted towards the postnatal period because the mother is now being treated. Okay? So postnatally, it's now take the children, half of these children get it from the breast milk. So the programs are now being should be on the strengthening of the early infant diagnosis and so that the infants should be tested throughout the entire exposure period. And then the final diagnosis conducted 3 months after the breastfeeding ends or at 18 months of age, whichever is later. So for the PMECT, the key points would be these are very effective programs that really provide the access to interventions and then reduce the rate of your PMECT. All the drugs are free, coming from the treatment hubs and all the clinics, HIV clinics, and it would actually we would like to emphasize that the risk of transmission to the infant is actually highest if the mother's viral load is also high. So we also want to emphasize that these services should be available on the antenatal clinics or at early point in the range of these services that we have identified earlier. Now, the future of your PMPCT programming. Although we are trying to go through the elimination of the transmission, there are more things to emphasize on, which is number one would be effective counseling, and then of not only the mother, okay, and the caregivers, but also the whole family. It has to be a community-based support and peer support. Most of these mothers are lost to follow up. Our number one problem in our clinics, Nicole, our fellow before, did a study on the follow-up of all these babies, and we only have them up to 6 months, mostly up to 8 weeks after. Because once they tested negative for the initial test, they won't come back anymore. So the problem there would be those who are breastfeeding or probably they are not confirmed yet, okay, to be negative. So that's number one problem. Majority are because the mothers cannot bring them to the clinic because they also go to the clinic of adult HIV. Okay. The other would be the rapid expansion of point of care, early infant diagnosis. Okay. As of now, the confirmatory test that we do and submit to the laboratory, the turnaround time is about 4 weeks. So what we do is really initiate the treatment and then wait for the confirmatory test to be negative before we stop the prophylaxis. Next would be the areas of concern. Number one is the maternal viral load. So we have seen that it is really very important for us pediatricians to know the maternal viral load of the mother because that would really affect the prophylaxis that we're going to give to the child. Number two, breastfeeding. And I have addressed this already, and we are going to log it to DOH to include an option for a replacement feeding because we all know that there's transmission through breastfeeding. And the availability of your ARTs for children because we are having so many problems with the preparation and because there are only limited types of drugs that are available for infants and children. Just one note, the WHO has already declared that if your viral load is less than 1,000 copies per ml, it's equivalent to non-transmissible. Okay? So that's already a fact now that we follow. But does this apply also to breastfeeding? So WHO said, however, no, the research on breastfeeding women living with HIV that includes the viral load data is limited. So what evidence does exist indicates that the undetectable viral load provides significant protection from HIV transmission. However, there have been cases of HIV transmission among breastfeeding women with undetectable viral loads. So currently, most of these developed countries recommend women living with HIV not to breastfeed at all, okay, whether they are virally suppressed or not. So, because they are able to provide for the AFAS that we have. So, acceptable, clean, safe water. Okay? I think the Philippines is not like Africa. No? We have the same water. Okay? Economically, medyo up naman tayo. So I hope in our setting, we should consider this as our stand, no? For this small population of breastfeeding women with HIV. So I hope with this, these are my resources, other resources, okay, for the slides that I have. And the next message would be for us to now speak up about all the local data that we have, okay, and also for the provisions that we now have the HIV law, okay. And I can tell you na hindi pa ako the IRR is not yet out because marami pa ho kaming issues on them. So I hope you will also get your issues on the HIV management of children, adolescents, and adults. So with this, thank you very much for your attention.
Thank you, Dr. Pagcatipunan. Are there any questions from the audience? If sumagot na kasi si Doktora kanina ng question. If there are not, if there are no more questions, maybe we request Dr. Erwin de Mesa to award our certificate of appreciation, and also for Doctora to sign our commitment board.
While Dr. Pagcatipunan is signing on our board, maybe it's a certificate of appreciation is hereby given to Marimel G. Reyes Pagcatipunan in grateful appreciation for sharing her invaluable insights and expertise as lecturer on the topic Prevention of Mother-to-Child Transmission during the HIV Summit. Know Your Epidemic, Know Your Response, given on the second day of August 2019, MK Tan Hall, Bayanihan Center, Unilab Laboratories, Pasig City, signed Annalisa T. Hong Lim, President PSMID, yours truly, President PSOG, and Dr. Mario Panaligan, President of PSMID.
Thank you, Dr. Pagcatipunan and Dr. De Mesa. We'll have a little more interactive session now. Hopefully, we'll just have a late lunch, pero medyo busog pa naman yata tayo. Sana. But this will be a more interactive session. So this will be a panel discussion. We have 5 panelists chaired by the president